My name is Katie Golden, and thank you so much to the American Medical Women's Association for having me. I am a patient advocate. I'm actually not going to tell you what chronic pain condition that I have. I'm going to do some medical storytelling and have you guess what it is that I have. So I'm kind of going to present to you my case just as if a med student or, sorry, a resident were presenting to their attending. So I'm going to use a lot of medical terms. It would be great if you could maybe take note of how many of the medical terms that I use that you're unaware of. And I know that we have a wide and varied audience, but I think some of the things that I experience, a lot of people never even heard of. So let me give you my medical background. I am a 39-year-old white female. I have no children, don't smoke, occasional social drinker. I do have von Willebrand's disease and inactive tuberculosis. My surgical history, I had an ASD repair at age 4. I had a cholecystectomy at age 17 and a Nissen fundoplication, say that 2 times fast, at age 18. My symptoms that go along with my diagnosis that I experience almost on a daily basis. I have allodynia, extreme fatigue, nausea, occasional tinnitus, phonophobia, photophobia, olfactory and gustatory hallucinations, aphasia, impaired cognitive dysfunction, photophobia, occasional scintillating scotoma, and occasional paresthesia. When I know that my pain is going to flare up or increase in severity, these are some of the warning signs that I have before that happens. I experience excessive yawning, mood swings, dizziness, hiccups, irritability, frequent urination, hot ears, difficulty finding words, and dysmegalopsia, which I'm sure I'm not saying right. But that is also known as Alice in Wonderland syndrome. So my chief complaint, excuse me, is that for the past 10 years, I have lived with chronic intractable pain. I am 24/7, 365 days. I experience many of these symptoms. My chief complaint, my pain is mostly around my left temple and behind my eyes. I'd say it's often throbbing and piercing and daily pain levels for me because I am daily chronic experiencing this disease. It can go from 3 pain level in the morning, and at night I'm at an 8. Or I can have long periods of time where I am steady averaging at a 5, which is to me now, because I have some better coping mechanisms, a 5 is just kind of annoying. So we'll ask you later what chronic disease you think that I have. And so I also wanted to give you a few points so that you really understand when patients come to you. The I guess give some kind of some advice, some insight into what we're feeling, and seeing if this may help you in your practice or in your practice going forward. Chronic pain patients often know as much about their condition as you do. I think I just illustrated that in a way, but of course, this has been 10 years of me dealing with this, so I have researched and researched and researched. It's often very frustrating to go to a doctor and hear the words, oh, it's just stress, or there is nothing that I can do for you. Actually, those words, there's nothing I can do for you, is the worst. And it's not true. Let me say, maybe you can't do anything for them, but you could refer them to somebody. So if you're not a specialist, you don't know a lot about the condition, having somebody on your side and really, really trying to help you in your journey. I mean, this is scary. This affects our lives, our day-to-day lives. So saying, I can't help you, but I'm going to talk with a colleague, or I'm suggest maybe that you see this person or that person. And oftentimes, patients can definitely feel bounced around, but hopefully they have a great healthcare provider that will stick with them, general practitioner that will help them through the process. And I'd say also that patients want to know what your idea is for their treatment plan, no matter what they have, if it's an ongoing condition. For somebody who's chronic, most of the time there is not a cure. Hearing those words is hard, life-changing, and can also seem very, very daunting and scary. Um, so in coming up with a treatment plan, the best thing that my doctors have ever done for me is say, okay, we're going to do this first. And then if that doesn't work, we're going to try this for X amount of time. If that doesn't work, then there's this other thing. And maybe also tell me a third line uh, of treatment, just so that I don't feel like, okay, I'm going to get this medication or try this new treatment and it's going to cure me, or I'm going to feel better immediately. Um, People with chronic pain conditions often have comorbidities as anxiety and depression. And so sometimes we put our hope into the one thing that you give us. And we're like, if this medication or this treatment fails me, then what am I going to do? I don't want to live like this the rest of my life. So the doctor-patient relationship is so incredibly important. And again, especially for chronic pain patients, it's a partnership. You don't get to fix us and we'll never see you again. There are other specialties that and other conditions that, you break your arm, usually you can fix that and you don't see the person again. But there are 50 million Americans who live with chronic pain. It's a lot. And they're all different types. So I think really, I also want to reiterate, I've been doing this as in advocating for patients for 10 years because I didn't have a choice. I was the youngest vice president of my small community bank in DC, working in construction real estate finance. And when this hit, I tried horribly for 2 years to work and I had to stop working. And that crushed me. I loved my job, crushed me. I had to find a new identity. And I'm so grateful to the physicians, all the healthcare providers, nurse practitioners who have been with me, excuse me, along the way. And if I miraculously got better in the next day or so, would I go back to banking? No, I would go back to fighting for patients, no matter what their disease is, and helping others to understand what life is really like. I have chronic intractable migraine, also known as status migrainosus. I also have occipital neuralgia. And there are actually, if you don't know, there are 300 types of headache diseases in the International Classification of Headache Disorders. There are over 300 types. So just saying that I have migraine 24/7, 365. I'm special. Wish I didn't belong to this club, but I do. And I've found some amazing people and amazing partners along the way that have helped me tremendously. I was lucky enough to be on the waiting list to see a headache specialist who is Dr. Alani at Georgetown University. She's a neurologist who took an extra year fellowship to become a headache specialist. And so she only sees headache patients. And when I say headache patients, I mean headache can be migraine, hemiplegic migraine, um, intracranial idiopathic hypertension headache, cluster headache. So it's kind of a broad term. And you probably also notice that I say I have migraine attacks and I have migraine disease. It is a neurological genetic disorder that presents in some people, and in some people it doesn't. And so I was lucky enough to see Dr. Alani at Georgetown when this first hit me. And she did get to a point where she said, I have no clue. You It was about 3 years into it. She's like, you've done everything that I've asked you to do, and I don't have any more tools. But I know somebody who might. And she referred me to the Jefferson Headache Clinic in Philadelphia, which is actually where she trained. And my biggest, the thing that helps me the most, I would say, is the basis for my treatment plan was discovered there. For me, it was discovered at Jefferson. They have a 5-day inpatient uh, ketamine infusion. So an IV drip of ketamine, 5 days. And I do this about once a year, and it dramatically decreases my average pain level. And I also have a nasal spray that I take at home. So when things start to spike up, I can use that. I've probably done this protocol about probably close to a dozen times. But then also, and obviously I am a severe case, but on a daily basis, I take old school preventatives. Um, I'm on amitriptyline and have been since I was a teenager, Effexor, and all the preventives, old school preventives, used off label. So anti seizure meds, calcium channel blockers, beta blockers, things like that. But in the past few years, if you haven't heard or don't know, there are a new class of drugs called calcitonin gene related peptide inhibitors, CGRP. And these preventives are taken as a shot once a month. And so I am on one of the 3 that are on the market. And that has absolutely helped for things to continue to remain steady. But also when the pain just flares up and it's just really, really bad, the triptans stopped working for me a long time ago. And now there are a new class of medications called GPANs and DITANs. And so the GPANs are kind of like the preventive medications, but they pack a punch. They're small molecule monoclonal antibodies, and taking those can help to reduce the severity of my my attacks tremendously. So there are a lot of new medications on the market, and it's really, really exciting. And there are some new things that are still yet to come out. So if you need more information on that, happy to tell you.